And next, we've got Rebecca Glassman.
Everyone is waiting on you.
Okay. Does anybody know this song? Sound familiar? So Orange is the New Black theme song, and while our residents are not doing time or mandatory time, we like to think of the long block as really giving our primary care residents more time, and specifically more time in the ambulatory setting. Primary care program is not something new to Beth Israel Deaconess Medical Center's internal medicine residency program. It's existed before. All of our residents are on a 3+3 model, where they spend 3 weeks in the inpatient setting and then 3 weeks in the outpatient setting. And you can see I've highlighted in yellow here what a typical internal medicine resident's time in outpatient would be. So 1 week dedicated of the 3 in the outpatient setting. This doesn't differ a lot from the categorical residents. They have an additional second clinic, but otherwise their curriculum was pretty similar to that of a categorical resident. And so the program leadership at Beth Israel said we need to give these residents that are interested in primary care more time in the outpatient setting. And so they looked at how to do that and created a program that would increase in outpatient time in their 3 years of residency to almost 50%. It would double almost the number of clinic sessions during this time, and as a result of that, allow them to care for more patients during their 3 years of residency. So what's beautiful about the long block is that every day is different for a long block resident. The structure is such that during second and third year of residency, our primary care residents spend 6 continuous months just in outpatient, which is amazing. 6 months, uninterrupted. They don't have to go to the ICU. They don't have to go to the wards. They don't have to do night float. They're just in the outpatient setting, taking care of their patients. As you can see here, they're spending tons of time in their continuity clinic. This allows them to follow patients through with subacute issues, acute issues, see these problems through, titrate blood pressure, manage diabetes in a more continuous manner. It allows them to participate in specific electives and chronic disease clinics so that they can hone their skills in some of these subspecialty areas where they might not feel they have the same amount of comfort. And then it allows them to really become leaders in primary care. So I'd like to show you a couple of examples of that. Our residents are serving as teachers for the Crimson Care Collaborative is the Harvard Medical School student faculty clinic, and our residents are in that clinic every Tuesday evening serving as preceptors. They are serving as teachers to each other through a primary care curriculum where they're leading discussions on a weekly basis. And then they're teaching their patients by facilitating group visits. And they're all going through a clinician educator lecture series so that they can improve their ability to be teachers to each other, to their patients, and to medical students. They have multiple leadership opportunities to gain skills as leaders, but also to serve as leaders. They're working in our outpatient clinic and our healthcare associates. They are our team ambassadors serving to help improve the practice, and by participating in the Academic Innovations Collaborative through the Center for Primary Care, which is bringing together all of the primary care practices across the Harvard institution to improve how primary care is delivered, and more specifically, how primary care education is delivered. And then in this past year, our residents also participated in SGIM Hill Day. They're participating in lean training so that they can become really efficient in their future practices, and this plays out really nicely when they're working on QI projects within our own practice. Last year, our residents looked at the USPSTF guidelines for early lung cancer detection, and they said, how can we implement these recommendations into our own practice? And so they used their lean training to go to Gemba, and they said, In HCA right now, we're using a lot of redundant processes, we're using a lot of paper charts, and we don't have a lot of data to be able to pick out of our online medical record who might meet criteria for the screening. And so they updated the social history for our online medical record, so it's now retrievable data that we can use to be able to identify which patients meet these screening criteria. And since we are sitting at an innovation conference, our residents are innovators. Last year, our residents looked at the issue of no-show patients, fondly known as DINKs, do not keep. And they looked at our own practice, which shows that in the faculty practice, nearly 20% of patients don't keep their appointments. And in the resident practice, 30% of patients don't keep their appointments. So again, they applied their knowledge from their lean training. They went to GEMA. They looked at the process of how residents, how patients schedule their appointments, how they might cancel or be reminded of these appointments, how they reschedule appointments, and found several different ways to try and improve outreach to the patients to try and reduce the no-show process. So really, our primary care long block is 6 months of a sustained immersion in outpatient medicine. It's allowing our primary care residents to truly be leaders in primary care, and it's giving them the flexibility and creativity to create their residency around areas that they want to improve. And so I think the best way to show you that is to allow them exactly 1 minute to tell you why long block is so great.
The long block was really a great opportunity for me to see what the life of a primary care doctor actually entails. I think as a resident, one thing that's really hard for us is that we do feel a lot of tension between our inpatient and our outpatient responsibilities. And being immersed in the long block was really a chance to dive into primary care, follow my patients very closely.
One of the patients that I remember was a woman who came in to see me with an aortic dissection after being discharged from the hospital. Her primary care doctor was on vacation for about 3 weeks, so I had the opportunity to see her and see her again a couple more times, and then eventually get her in to see the surgeon to get operated on. It was a great opportunity for me to be her kind of temporary primary care doctor, which is not something I was able to do when I was only in clinic once every 6 weeks or so as a regular resident. And it was something that the long block schedule allowed me.
For me, I feel that it's given me the opportunity to practice real primary care, a lot more comfortable in the outpatient setting with all these additional experiences that I've gotten through the long block.
Thank you so much.
Great presentation. So you mentioned your residents are doing group visits, and I think it's great because it's a great learning experience to sit with the patient and learn from them. So what does the group visit look like, and what's the structure?
Our residents that are partaking in the group visits are sitting right here, right now, and probably can speak to that better because this is a new experience for all of us. But the residents are counseling the patients. They are doing hypertension management in their group visits and diabetes management, primarily diabetes management. It's a multidisciplinary session. They meet with nutritionists, with nurses, and with the physicians, and our residents have an opportunity to serve as educators to facilitate the conversation between the patients as well. They're actually also, as part of this year's innovation project, going around to all of the different practices around the Boston area to see how each of those practices is doing group visits and trying to improve our own group visits right now.
Thank you. You're welcome. You're welcome to Somerville Primary Care. We have a lot of group visits going on.